on ANCA vasculitis. I've known Michael for many years, since his time as a fellow in Cambridge when he was working with David Jane. Michael graduated from medicine in 2001 and completed nephrology training at University of Calgary by 2006, and there followed a fellowship in lupus and vasculitis in Cambridge under the stewardship of Professor David Jane. He completed a PhD at McMaster University in 2014. Currently, he's Associate Professor of Medicine, Nephrology, and Medical Director of the Glomerulonephritis Clinic and Director of the Clinical Nephrology Research Group at St. Joseph's Healthcare. Pertinent to this talk, Michael was lead author of the PEXIVAS paper published in the New England Journal of Medicine in 2020, and PEXIVAS was and will probably remain the largest clinical trial in ANCA vasculitis. I will say no more, but I would like to invite Michael to start his talk. We are indeed very lucky, fortunate to have such an eminent speaker. Over to you, Michael, if you would not mind to share your slides when ready. Thank you, Michael.
Thank you so much, Chen Au, and thanks to you, Professor Bhowmick, and Dr. Ramachandran, and to Dr. Pei, or Professor Pei, and Professor Sharma for inviting me and moderating this talk. It's a real privilege and an honor. So I'm going to try and cover a fair bit of territory around the treatment of ANCA-associated vasculitis. And I'm going to go a little bit faster through some parts that I think are probably a little bit contentious or a little bit less relevant. And we'll try and concentrate a little bit more on some of the more contentious areas. And of course, some of that will stem back. So where am I? This is a bird's eye view of Hamilton, McMaster University. And you can see the medical center is over here in the top right center. Unfortunately, that was actually largely decommissioned from adult care, and it's almost entirely a pediatric hospital, which is really too bad because I live right there, right next to it. I can almost throw a stone at the hospital from where I live. And instead, I work way down here at St. Joseph's Healthcare, Hamilton. That's actually only about 5.5 kilometers. But it's beautiful this time of year. I encourage anyone who wants to visit McMaster to come and enjoy the fall colors and look me up if you happen to be in the area. Potential conflicts of interest, I must say none of these are probably at all relevant to this. I don't actually take any money from industry. It all goes into nonprofit research organizations. And I'm going to start off with a summary. So if you're here early and you have to leave because it's getting late, these are my take-home messages. Immunosuppressive medications such as cyclophosphamide or rituximab actually perform very similarly in terms of initial disease control. So we don't necessarily make a lot of differentiation on the basis of their efficacy. Faster tapers of glucocorticoids do seem to reduce serious infections, which is the most common cause of death for patients who have ANCA-associated vasculitis. Plasma exchange does reduce the risk of permanent dialysis, but it also increases the risk of serious infections. And as a side note, it does not seem to change, at least not substantially, the risk of death within the first year. And as we think about now that this is a chronically remitting and relapsing disease, different patients that we see will have very different risks of relapse. And actually, for the nephrologists in the crowd, creatinine still tends to go a long way in terms of prognostication. So we'll come to that towards the end as well. Okay, so how are we going to get there? Well, let's go through two very prototypical cases in my mind. So one, a 66-year-old male presents with fatigue. The creatinine is elevated at 470 micromoles per liter with a known baseline of about 91 microliters 5 months prior. The urine is active. The patient is anemic, but there's no obvious diffuse alveolar hemorrhage either on X-ray or clinically. And he also has some sinus pain and arthralgia. And testing is done that shows a moderate titer PR3 and a negative anti-MPO. So a renal biopsy is done, which shows focal necrosis and crescents with mild interstitial fibrosis. Contrast this with a 58-year-old female presents with hemoptysis. She has a creatinine of 97, which is perhaps a little bit higher than it was last year when it was recorded at 61. She also has an active urine sediment. And she has clear diffuse alveolar hemorrhage on bronchoscopy with increasingly bloody washes, a hemoglobin that's 77, and she is modestly hypoxic with a room air sat of 88%. She has some arthralgias, and she has a very high titer MPO. And this is, of course, a very poor image, as it's a bit pixelated, of a renal biopsy that is representative of the first case, where there is some focal necrosis, classic for ANCA-associated vasculitis. There's been some crescent formation and some glomerulosclerosis, a little bit of ATN overlying. The immunofluorescence is still posse immune, and there's no dominant staining, and there's no particular pattern to it other than some mesangial scattering. And the EM shows no immune complexes. And if you look at Annalise Burden's proposed classification, this would be considered a mixed class biopsy. So the first question I always pose to myself is, why is this important? Why do we worry about patients with ANCA-associated vasculitis, or why does it generate so much interest? Well, the incidence for an autoimmune disease kind of borders on the common for autoimmune and uncommon. It's an incidence of at least 10 per million per year. It's probably a bit higher. The harder we look, the more cases we find. And a prevalence of somewhere between 100 and maybe up to 200 per million. So for Canada, that's not a lot of people, but in India, that would be a substantial number of people who are still affected. The first-year mortality is still what stands out. So the first-year mortality is about 12%, so more than 1 in 10 patients who are diagnosed are expected to die within the first year, and that's about a 6-fold increase over the age-matched norms. And that continues at a lower rate, but still increased at about 1.3-fold over the next 5 years. That mortality in that first year, which is where it's really steep, about a third of it is due to ANCA-associated vasculitis still. So we consider this either poorly controlled or incompletely controlled disease, but half of it is due to infection. And because we tend to think about the infections as being directly due to our therapies, I think it really gives us a pause to think about rational therapy for these patients. And for, again, as a nephrologist, I tend to think about things in terms of patients who had their kidneys affected, and certainly they are worst. This is just looking at patients who have an EGFR less than 50 at the time of diagnosis. Despite effective therapies, there is still a large number of patients who either don't recover from acute renal failure at the beginning and end up on dialysis, or they pass away very quickly. And so you'll see at the first year, it's greater than 25% of people who have their kidneys at least measurably affected in terms of EGFR will have either end-stage kidney disease or pass away within the first year. So there's lots of standard treatments out, and between all of the different guidelines that are currently available, KDIGO, ACR, several national bodies, you can come up with all sorts of different regimens, most of which there is only minor differences in terms of preferences for. So I've sort of listed them out here. The top 3 lines are the various kinds of classic cytotoxic immunosuppressives. So rituximab has gained a lot of traction in the last decade. IV cyclophosphamide and oral cyclophosphamide still exist, and they're more readily available in many places. Glucocorticoids is one of the cornerstones as a tapering regimen, plus or minus longer durations, and then plasma exchange and potentially other adjuvant therapies during the initial course. And then during the maintenance therapy phase or prolonged phase, then thinking about maintenance drugs like rituximab, azathioprine, mycophenolate, or even methotrexate, and potentially other medications as well. So we're going to go through each one of these 4 different distinct areas: immunosuppression during the corticoids during the initial phase, plasma exchange, and then maintenance therapy. So one of the things that I think is important to try and ground our decision-making about therapies when we have multiple different options is, what are we really trying to achieve? And what is our patient at risk of? So as a nephrologist, of course, I'm a bit biased, as I tend to think about all patients as being separated into the degree of kidney involvement they might have. As it turns out, I might be somewhat justified in this case. So patients with mild kidney involvement tend to be at fairly low risk of death, low risk of kidney failure, relatively low risks of infections, but they do have higher risks of relapse within the first 5 years. When we go to patients with moderate kidney involvement, and here we're thinking about creatinines in the 200 to 400 sort of micromolar range, their risk of death is still relatively low, but their risk of kidney failure is starting to creep up, their risk of serious infection creeps up, and their risk of relapse starts to decrease a bit. And as we get to patients with severe kidney involvement, so these are typically patients classified as having creatinine of greater than 500 micromolar or requiring dialysis at presentation, their risk of early death is much higher now. Their risk of kidney failure is much, much higher, but so is their risk of serious infection. And interestingly, their risk of relapse, despite having a very severe presentation, is relatively low over the next 5 years. There is a caveat around the early death is that patients who have severe diffuse alveolar hemorrhage, not mild alveolar hemorrhage, but severe alveolar hemorrhage, can have a moderate to high risk of death as well. So I would put out there that initial kidney function helps prognosticate several important outcomes. Infection remains the most common cause of early death for all categories. And those who are at the highest risk of relapse typically have the lowest risk of death and kidney failure. So you have to kind of think about the long-term lens with those folks, not necessarily just the short-term outcomes. And of course, quality of life can be very low for all of these patients, regardless of their risk of death, kidney failure, or serious infection. And so there is a need to make sure that they all have high quality care and have their disease controlled. Okay, so let's go through each of the therapeutic kind of cornerstones of the management of ANCA-associated vasculitis. First of all, the initial use of glucocorticoids. So I think this is a very fitting phrase. It's a phrase by someone named Colleen Hoover, who actually I had never heard of before I started trying to Google phrases that expressed how I feel about glucocorticoids. I've never loved someone I hate so much, and I've never hated someone I love so much. I think that's particularly fitting when we think about glucocorticoids. We love all the benefits and how effective they are, but we hate all the side effects. Well, so why do we use them? Because they work. In fact, this is one of the first controlled studies of glucocorticoids published in 1960 from the group in the UK. They looked at a small number of patients by modern standards, but what they demonstrated, as you'll see, is the percent alive in this right-hand column for those who were treated, who received glucocorticoids. It's up to 60% at 3 years, only 37% in the untreated category. And in fact, the mortality rate in the first 12 months was extreme because as you survived the first 12 months, then you kept on going. But there was a pretty high attrition rate up to that 60% in the first year. That gives a relative risk of about 50% for those who are treated with glucocorticoids. That's a huge treatment effect. And arguably, that was the single biggest advance in the treatment of ANCA-associated vasculitis. But of course, glucocorticoids aren't perfect. One of the biggest issues that was noted was that patients had to stay on reasonably high doses for long periods of times to prevent relapses. And of course, on those high doses, there was a number of side effects. So glucocorticoid experts sometimes divide these into sort of two categories, those that have a threshold effect and those that have a linear dose relationship. So that the higher the dose, the more commonly you get each of these kind of side effects. So Cushingoid features, ecchymosis, edema, mycosis, skin changes, and sleep disturbance all have a sort of a linear relationship. Doses above 7.5 milligrams seem to be able to cause glaucoma, depression, hypertension, epistaxis, weight gain, cataracts, osteoporosis. Now, the degree to which that is purely a threshold effect, I don't think anyone truly knows because there really is not enough controlled work in that area. And of course, then there's other sort of idiosyncratic side effects such as avascular necrosis, which may be actually a combination of both threshold and linear effects as well. And this leads us to this sort of paradigm where we're worried that if we give too little treatment, we'll have uncontrolled vasculitis. We won't get very many infections or other side effects, but people will have a tough time with their vasculitis itself and potentially progressive organ injury. If we give too much therapy, though, we've put people at risk of all sorts of side effects, increased infections, long-term malignancies, that their vasculitis, it might be controlled, but then they might be dying of cardiovascular disease and all these other issues. Now, because glucocorticoids had not really been systematically studied again since the 1960s, and there had sprung up a number of different people's opinions and protocols around how glucocorticoids were used in the early treatment of ANCA-associated vasculitis, we launched this clinical trial called PEXIVAS, which both explored glucocorticoids and plasma exchange. Very quickly, in the glucocorticoid component, we randomized patients to one of two types of regimens of glucocorticoid tapers over the course of the first 6 months. All patients would receive between 1 and 3 grams of methylprednisolone, and then they would all enter into a weight-based strata of oral prednisone or prednisolone. The reduced dose group got about 54% of the standard dose group over the first 3 months and about 61% over 6 months. And you can see that the biggest change here is really in those first few weeks. What we would do is everyone got a high dose of a maximum of 75 milligrams for the first week. And then the reduced dose group dropped that dose by 50%, where the standard dose continued on for 1 more week, and then made modest reductions on an every other week basis. We recruited 704 patients. You can see the demographics here. I would say that this is actually pretty reflective of my practice to be of older age, in their 60s. There was a very slight male predominance. And like many nephrologists, we saw more MPO positive patients than PR3 positive. Lung hemorrhage was included here, and there was about 61 patients who had severe lung hemorrhage and almost 200 patients with some degree of lung hemorrhage. The creatinines had a median of about 300, so they were fairly advanced, and about 20% of all patients required dialysis at the time they were diagnosed. About 30% almost had a creatinine of over 500 micromolar. And the types of immunosuppression that were started on these patients was pretty reflective of the era in which we did this, which was over almost 8 years. And that included about half on IV cyclophosphamide. It was almost immediately post the Cyclops trial era. And rituximab was just picking up at around 15%, with the remainder on oral cyclophosphamide. So what did we show? So we had a primary composite outcome of all-cause mortality and end-stage kidney disease. And what we wanted to show with the glucocorticoids was that we could have similar clinical outcomes with a reduced dose of glucocorticoids, but fewer serious infections. So this primary outcome of end-stage kidney disease and all-cause mortality in the standard dose, 26% of patients had this outcome versus 28% in the reduced dose, so almost identical. The absolute risk difference was 2.3%. The 90% confidence interval had an upper bound of 8%. Our limit for being able to call this non-inferior was 11%, so we met that. In fact, this is actually a very conservative way to estimate this difference between the two groups. Probably a more accurate way gives an upper bounds to the confidence interval of only 5%. And you can see here in the survival curves that, in fact, the standard dose did a little bit worse over the first year, and then they start to catch up, and they're basically parallel after that. When we looked at secondary outcomes, the one of most interest was the first year serious infection. So it was in the first 6 months that we really had the separation in doses. And so the first year infections, which is where most infections actually happen, is what we were interested in as a readout on the effect of dropping the dose of glucocorticoids. And there was, in fact, a reduced risk of serious infections, about a 30% fewer infections during that first year, which was substantial. There was no difference in any of the other components or in other outcomes that we looked at, including sustained remission. Now, we weren't the only ones to do this. In fact, our Japanese colleagues, led by Shunsuke Furuta, did a very similar trial called LOVAS subsequently. This was 140 patients in Japan. They were all treated with rituximab as their induction immunosuppression. And their primary readout was at 6 months looking at remission. And then they were followed for an additional 6 months. Now, these are lower risk patients. And we'll see here that the amount of glucocorticoid reduction for these patients was actually really substantial. So we have the PEXIVAS dosing on the right-hand side and the LOVAS dosing on the left-hand side. The LOVAS, what they call the high dose group, was actually slightly higher, about 10 to 15% higher than the PEXIVAS standard dose, but their low dose was substantially reduced. And in fact, it was about a 70% decrease in the prednisone exposure, the cumulative prednisone exposure in the low dose group. But as I said, their patients were sort of a different risk profile. They were older, and they had more females, predominantly MPO positive, which is very common for Japan, but actually very little renal involvement with a mean GFR of about 54. And long story short was that disease control looked very similar, very little difference in terms of disease activity over that first 6 months, but that there was a substantial drop in infections. Now, there isn't a lot of infections here to actually work with, so the precision is not wonderful, but the risk ratio is represents about a 70% decrease in infections compared to about a 30% decrease in PEXIVAS. And that is a 70% drop in prednisone then leads to a very similar sort of drop in serious infections. So we summarized this data in a BMJ rapid recommendations earlier this year. And we said that essentially reduced dose regimens of glucocorticoids may reduce the risk of death. There's relatively low certainty of that though. They're unlikely to increase the risk of end-stage kidney disease, moderate certainty of that statement. They have a reduced risk of serious infections. Again, we're moderately certain of that. And there was really no other effects on outcomes that were considered important. And so our recommendation at that point is that there really isn't much of a reason not to use a reduced dose regimen. Now, because PEXIVAS had a lot more data behind it than low-VAS, and low-VAS had a relatively restricted population, our recommendation was typically to think about PEXIVAS first, and in selected patients, think about potential for low-VAS. But along comes perhaps even more radical changes to glucocorticoids. I think this is one that has generated a lot of talk in the last year and a half, is what about just getting rid of them altogether for an alternate agent that doesn't have all of the side effects of glucocorticoids? And now a reasonably large trial called Advocate that tests a C5a inhibitor, Avacopan, has been published in February 2021. And so this was a double dummy RCT that randomized patients to either Avacopan 30 milligrams twice a day, ending on 52 weeks of therapy, or a tapering course of prednisone that ended on week 20. I think that's an important distinction when we think about the pros and cons of how we interpret the results of this trial. The primary endpoint was looking at 26 weeks, and it required there to be no disease activity and no steroids given for the 4 weeks prior to be considered in remission. And this is only 6 weeks after the proposed taper of prednisone, while patients were still on active Avacopan in the treatment arm. And their other endpoint was a sustained remission at 52 weeks, which required no disease activity or steroids and no relapses to have occurred during that 52-week period. So again, just looking at the patients that were included. So there was about half as many patients as there was in PEXIVAS. Again, the average years, there was a slight MPO predominance, and there was no patients with lung hemorrhage or severe lung hemorrhage, at least. They didn't report on other lung hemorrhages. And their GFR was a little bit lower than the low-VAS population, but not nearly as low as the PEXIVAS population. So not quite as high risk of death or end-stage kidney disease, but probably a bit higher risk in terms of relapse. And if we take a look at their targeted prednisone dosing, I think the important part here is if you look at the Advocate prednisone group, they're about 10% more prednisone exposure than PEXIVAS, but the shape of that curve is also a little bit different. It's a little bit front-loaded, and then they go down to 0 milligrams at the 20-week mark. So in Advocate, the outcomes were quite good overall, particularly if you think that many of us were worried about getting rid of glucocorticoids altogether early on the development of this molecule. At 26 weeks, there was remission very similar in both groups. Met its non-inferiority hypothesis. At 52 weeks, this suggested actually there was a slight superiority to Avacopan. Again, I would just frame that the Avacopan group received active therapy for all 52 weeks, whereas the prednisone was stopped at 20 weeks in the prednisone arm. There's these measures of glucocorticoid toxicity. I would put out there that when you test a glucocorticoid-free regimen to a glucocorticoid-containing regimen, you should, of course, expect that there would be more glucocorticoid toxicity in the patients who actually receive glucocorticoids systematically. And there was. The question then is that actually important? It's hard to tell with this glucocorticoid toxicity index. There's a suggested minimally important difference of about 11 points, in which case the average passes that. But it's a very difficult index to interpret on a person-by-person basis. I like to look at the SAEs that were thought to be potentially related to prednisone. And you'll notice that it's about 14% in the prednisone group compared to about 6% in the Avacopan group. 14% in my mind in that first year is about middling. It's hard to tell exactly what goes into that potentially related to prednisone group, what kinds of SAEs they actually are. But that would mean that you would need to treat about 13 patients to avoid one prednisone-related SAE with Avacopan. If you live in a socialized Medicare kind of country like I do, though, the cost of the drugs is really important. We don't have it available in Canada right now, so I pulled this from online pharmacies in the States, and it essentially is that if you were to treat someone with a PEXIVAS low-dose regimen for 12 months, it would cost about $53 compared to about $163,000 for Avacopan. And so it's a fairly big price point difference to try and avoid prednisone side effects that occur in 14% of patients. So, summary here, glucocorticoids are effective, but they definitely do cause infections. PEXIVAS reduced doses was still as effective as higher dose regimens, but reduced the number of infections, and that's in patients with severe disease. We don't expect there would be any less effective in patients with less severe disease. The low-VAS regimen is kind of untested in patients with severe disease, but in patients with non-severe disease, you may want to think about really cutting lower. And it does raise the question as to whether or not we really know how far and how fast we can reduce glucocorticoids. And I think there'll be more research there in the near future that will help inform that issue. Avacopan still has relatively limited data in severe disease, but the importance of its benefits in moderate to non-severe disease over low-dose prednisone is still a little bit uncertain in my mind. It's almost certainly reduces glucocorticoid toxicity, but the degree to which it's an important reduction is uncertain. Okay, induction immunosuppression, the second pillar, I think the one that really received the most attention over the last decade or two. And so I always like to bring this up, partly because Dr. Fauci is going into retirement, at least from his NIAID position. And he was, of course, leading edge and a trendsetter in the vasculitis arena as well as in infections. And so this is a quote from one of their seminal papers in 1979, published in the New England Journal, where they had just started to treat patients with cytotoxic agents in addition to corticosteroids. And they found that, in fact, the addition of cyclophosphamide, as well as later methotrexate, allowed them to discontinue glucocorticoids in at least some patients. And there was a lot of then back and forth about the degree to which cyclophosphamide started to cause toxicity, and led to many trials looking at whether or not we could reduce cyclophosphamide toxicity by cutting its dose or replacing it with different agents. A few of those trials here, attempts at using pulse cyclophosphamide to reduce the dose of, compared to oral cyclophosphamide, roughly in half in the top left corner. In the top right corner is a rituximab that was looking at replacing most of the pulses of cyclophosphamide then with rituximab instead. And down at the bottom is the RAVE trial looking at rituximab compared to oral cyclophosphamide. In each of these, they essentially showed that the short-term outcomes in that first 6 months to 1 year were very similar, that almost always the same number of patients would enter into a remission. Unfortunately, the thing that I think a lot of people really wanted to see was that there would be fewer infections as well. Now, each of these trials is between sort of 100 and 200 patients, except for rituximab, which was only 44. And they probably did not have sufficient power to really show whether or not there was going to be a difference in infections. So we have then a number of trials comparing alternative agents to cyclophosphamide and alternative dose strategies for cyclophosphamide. And they all kind of show that the short-term outcomes are similar, that you really can't expect to get a lot of difference in terms of the number of patients who are going to reach a remission within the first 3 to 6 months. They do differ a bit in the longer-term outcomes. So over the next years, With strategies that reduce exposure to cyclophosphamide, there is a pretty consistent increase in the number of relapses. So in fact, cyclophosphamide seems to have a very long carryover. And the more cyclophosphamide you give, the more chance of toxicity you get, but you get a reduced risk of having relapses later on. So how does this actually inform the patients that we see? Well, if we think about whether or not this impacts their really important, serious short-term outcomes, death, kidney failure, serious infection, ability to get a remission of disease, there isn't a lot of difference. The only thing that's maybe a bit different is that oral cyclophosphamide likely leads to a bit higher risk of serious infections, but it might decrease the risk of long-term relapses. Maybe it's a bit better for short-term remission in patients who have more refractory disease, but that's a pretty contentious statement that's based on observations from historic data mostly. IV cyclophosphamide, at least compared to oral cyclophosphamide, might reduce infections a little bit. It doesn't seem to have a lot of other advantages. And rituximab, rather disappointingly, compared to both IV and oral cyclophosphamide, really didn't seem to change the risk of infection. Having said that, it was often given without additional immunosuppression after 6 months, so it makes it a little bit harder to tell. I added MMF at the bottom because we did do one trial in MMF, and there's some other small series of MMF, and again, not much difference in the way of the early data, but an increased risk of relapses. And of course, a lot of this might be just that the effects, the short-term effects of the immunosuppression are overshadowed by the effects of glucocorticoids during that time, which we know are very effective. So in terms of our induction immunosuppression, really similar effects from all agents, possibly due to the glucocorticoid effects. There are differences in terms of side effects. There's major differences in terms of availability, convenience, and logistics of arranging some of these things. But the long-term effects really do seem to have shown out on relapse, and cyclophosphamide has a very long carryover that really we see its effects on relapse lasting out to the 7-year mark. Okay, plasma exchange. So I think sometimes this is the one people are all waiting for. Really, the rationale for plasma exchange was pretty simple. ANCA appeared to be pathogenic and bad for people, so maybe we should take them out. It's a little bit more nuanced than that, in that really we're trying to get rid of ANCA during a time when we thought disease control was otherwise inadequate or incomplete, so that we would end organ damage quickly and allow patients the best possible ability to recover with otherwise effective immunosuppression and glucocorticoid dosing. So I'm not going to go through the design of PEXIVAS again, but remember that it's 704 patients. This primary composite is end-stage kidney disease and all-cause mortality. And we were looking for a relatively large effect here based on previous historic data, that we thought that this should be up to about a 30-35% risk reduction. Now, one of the confusing parts here, though, was that in the previous trials that had been done, there really wasn't a big effect on mortality. And we thought that that might be because, one, the previous trials were small and it would be hard to detect that, but two, that they might not have been long enough to actually see what the benefits of arresting kidney damage were in the long term. The other thing that we did that was slightly different is we included patients with lung hemorrhage because it was a bit of dogma based on some very small observational series suggesting that plasma exchange should be a major component of the treatment of patients with diffuse alveolar hemorrhage. So when we looked at this primary composite of end-stage kidney disease and mortality, it was experienced by 31% of the control arm, or the no-plex arm, and 28% of those who received or who were randomized to the plasma exchange arm. And you can see the survival curves here. Indeed, the plasma exchange arm does, with the eye of confidence or perhaps hope, looks a little bit better up in that first period. You'll see that there's this sudden jag in the lines at around 3 months, and that's because that's where our definition of end-stage kidney disease takes effect. And so that's where there's this jump here, and that's also where the biggest difference looks like it accumulates, is around that 3-month mark. And then it starts to collapse over time. And when we published this, I think there was a general sentiment that we killed plasma exchange, that it shouldn't be used. There was no benefit of, just discard it from your therapeutic armamentarium. But I try and point out that although PEXIVAS was the largest trial in the area, it wasn't the only trial. And in fact, prior to PEXIVAS, there had been a fair amount of information already accumulated. So 387 patients randomized who had experienced 183 of the composite events. And we added to that, we doubled it. But that means that PEXIVAS is still only around half or just over half of all of the available information. So there's 411 events after PEXIVAS in just over 1,000 patients. And the effect on the composite is pretty convincingly small. So if there is an effect at all, it's going to be quite small. And we couldn't show that that was outside the play of chance. But because there was so much more accumulated information, we had the opportunity then to look at individual outcomes rather than this composite primary. And this is arguably much more important. So in terms of end-stage kidney disease events, there was only 63 prior to PEXIVAS within the first 12 months. And we expanded that to 170 events in almost 1,000 patients by performing PEXIVAS. Now, the relative risk, which looked at a phenomenal greater than 50% reduction prior to PEXIVAS, dropped substantially. But even under a much more conservative way of looking at this, it was still outside the play of chance that this exists. And in fact, it's still a 40% almost reduction in the risk of end-stage kidney disease within 12 months, which is, you know, in terms of therapies to prevent end-stage kidney disease, that would make it probably the most potent that we have and one of the only ones that we have that for patients with an RPGN. So what does that mean in terms of other outcomes? Well, you see death there at the top, still a small, if any, effect, and we could not prove an effect outside the play, having a reasonable number of events within the first year. End-stage kidney disease, fairly large effect at almost 40% relative risk reduction. And something that was new for us was the discovery of a 27% increase in the risk of serious infections. And this was, of course, important because serious infections are still the most common cause of death, and they are the most common during the first 12 months. So if we put that together, it does appear that PLEX reduces the risk of end-stage kidney disease in the first 12 months, particularly, but it comes at the cost of an increased risk of serious infections, which kind of makes sense that we took out a whole lot of immunoglobulins during a time that patients were being immunosuppressed. And so there was no net effect on death. And I haven't shown the primary data here, but that included in the subgroup of patients who presented with diffuse alveolar hemorrhage. There was no effect on death. And that was the primary reason why people were looking at using plasma exchange in diffuse alveolar hemorrhage. And there's the primary data there that it's, as you can see, it's, if anything, even as smaller than the overall group. And those benefits that we see in terms of end-stage kidney disease, as well as the risks of serious infection, look like they attenuate over time, which is also kind of what we would typically expect for an acute therapy. And you can see end-stage kidney disease, it drops down to about 20% in long-term follow-up, and serious infections are now dropping to about 13%. So both of them are basically getting cut in half over a median follow-up of about 3 years. So if I've convinced you that plasma exchange reduces the risk of end-stage kidney disease, who should receive it? I've plotted here the risk of end-stage kidney disease within 12 months for patients who present with ANCA-associated vasculitis across their starting serum creatinine. So the higher your serum creatinine in that dark solid line, the higher your risk of developing end-stage kidney disease. You can see even at a 500 micromolar, it's about 15%. So depending on your view, that's either a high number or maybe not as high as you might have expected. If you also require dialysis, though, that number jumps up to about 30%. And that's definitely a high number, a 1 in 3 chance of requiring permanent dialysis if you present with a creatinine of 500. But I would argue that if you require dialysis, even if your creatinine was only about 300 or 350, you still have a 1 in 5 chance of requiring permanent dialysis within 1 year. And if you're presenting at 350, but not requiring dialysis yet, that's still a 1 in 10 chance, which for some people would be very high. And they might want to accept a therapy that reduces that down to only about 5 or 6% if they got short-term plasma exchange. So we can plot this out a little bit about what the baseline risk of end-stage kidney disease is by some fairly practical groups of serum creatinine. So below 300 as a serum creatinine at the time in which you're diagnosed, your risk of end-stage kidney disease is consistently less than 5%, and below 200, it's getting close to negligible. That risk with plasma exchange drops to about 3% for a number needed to treat of anywhere between 52 and 1,000, which is a lot of plasma exchange for an expensive invasive therapy. If you take a look at this group of patients who are at kind of moderate risk, 300 to 500 not requiring dialysis, so they have about an average risk of end-stage kidney disease of 11%. That drops down to 6.8% with plasma exchange, and you need to treat 24 patients then to avoid one case of end-stage kidney disease. When we look at patients who are on dialysis already or have a creatinine of greater than 500, the average risk there is about 40%. It drops all the way down to 25% with plasma exchange, and that means you only need to treat 7 of those patients in order to avoid one case of end-stage kidney disease. And I think for most people, that tends to be a pretty worthwhile use of plasma exchange. So there's been several guidelines that have been written now. They have interesting rationales. So much of it is based on the concept that there is in fact an interaction between kidney function and the effect of plasma exchange. The suggestion is that it works in patients with high creatinines and it doesn't work in patients with low creatinines. That's almost certainly not true. What happens is that there is a detectable benefit and much more easy to measure benefit in patients who have high creatinines because their absolute risk is high, and so they get a much bigger absolute risk reduction than patients who have lower creatinines. We found across the meta-analysis, there's no interaction. In fact, everyone gets the same kind of risk reduction on average. But if you're at very low risk of developing end-stage kidney disease, you won't get a lot of measurable benefit. It's going to be very small. Whereas if you're at high risk of end-stage kidney disease, it's a very easily measurable benefit. So what we had said is that we recommend weekly against plasma exchange in creatinines less than 300 because they have a low tendency towards end-stage kidney disease. It's weak because you have to still judge whether or not you think that that cutoff applies to that patient and whether or not their individual preferences would demand that they still want plasma exchange, even if there's only a small benefit for it. We had a weak recommendation for plasma exchange in patients with a creatinine over 300 with the same sort of caveat. Some patients you might see who have a creatinine of 301 and they get their first dose of methylprednisolone and the next day it's 170, probably wouldn't be worthwhile. But some patients, obviously, this is a very broad category, are going up rapidly. You may be much more likely to want to start it in them. And then we made a weak recommendation against plasma exchange for isolated lung hemorrhage because there's a very low probability of benefit, but there is an almost certain increase in the risk of serious infections. And of course, serious infections are the #1 cause of death for patients with lung hemorrhage. They die of infections actually mostly, rather than uncontrolled disease. For all of these, we suggest that you have to consider patients' values and preferences. And actually, we've done some work in this area now. And one of the things that we found is that physicians aren't very good at predicting what patients want unless the patient tells us that they want us to tell them what they want. So most of the time, it's, we do actually have a conversation to what degree they want to use plasma exchange for sometimes a relatively small reduction in the risk of end-stage kidney disease. So my plasma exchange summary: plasma exchange reduces the risks of kidney failure in patients who have renal involvement. The degree to which that risk is important depends on what their risk of developing end-stage kidney disease is, but it does increase the risk of serious infection, and it doesn't change the risk of death, which is why we were using it for DAH in the past anyways. I would reserve plasma exchange for patients who are at reasonably high risk of kidney failure and who are willing to take that risk of infection. So if we're fully informing them, they have to know that there is, in fact, a potential downside to plasma exchange. So very quickly on maintenance therapy. So we're into now this set of dotted lines and arrows on the bottom to the right-hand side. There's lots of different options. These are actually surprisingly less tested, perhaps, than the induction therapy. We really have been concentrating on safety and efficacy in the first year of treatment and not as much afterwards. But there's been two sort of major advances. I think the first is that we better understand who's going to have a relapse. I've shown some of my own work here, mostly because I'm the most familiar with it. But if we define out various risk factors for developing relapses in the long term, the ones that are patient-associated are those who have creatinine that's fairly low in the normal range at the time they present, that they're PR3 positive, and at least in 2 studies that they have cardiovascular involvement. We'd also consider, patients who have had prior relapses or who have persistent positive ANCAs, regardless of whether it's MPO or PR3, are also at higher risk of relapse. And you can see when we used just creatinine, PR3, and cardiovascular involvement, those with no risk factors still had about a 25% chance of a relapse at 5 years, but that rose up well past 50 into almost the 70% range for those who had 2 or more risk factors, which is really high. If you look at the right-hand panel where you only use creatinine, and I've tried to scale it a bit here so that the y-axes are more similar, creatinine actually explains a lot of the potential risk. So it's about the same as in terms of its strength of association as PR3 in this study. But this has to be studied more. The way in which we've been using kidney function is probably a bit crude and needs to be refined. But it does show that we have some very simple biomarkers that are very easy to measure both at baseline and later on to help identify what the risk is like for patients for relapse. So if we have some patients who are at really high risk of relapse, we might want to use more effective therapies for them, where the risk of side effects from those therapies might be a bit higher, but they also get a little bit more benefit from them. And in patients who have very low risk of relapse, we might want to reduce the amount of immunosuppression or medication exposure that they get to try and reduce the number of side effects that they may get. There's 2 reasonably well-established ways of doing this. On the left-hand side show a study called REMAIN, which looked at prolonged treatment with prednisone and azathioprine. And you can see the treatment schema up top, where patients receive 5 milligrams of prednisone and 1 milligram per kilo per day of azathioprine for several years after having having remission induced, versus having it tapered pretty quickly at around the 2-year mark. And there you see that as soon as the medications are discontinued, and the W stands for withdrawal group, which is the red line here, that as soon as the medications are withdrawn, you start to see that their relapses start to accumulate. Even in this continuation group, the C group on the blue line, once treatment is withdrawn at around the 1,000 day mark, 3 more years, it does look like there's a bit of drop off. It's hard to tell whether or not that's just small numbers, but certainly there's a big difference in the relapse risk while people are on therapy versus not on therapy. Now, whether that's the azathioprine or the prednisone or both is a little bit uncertain, but longer therapy does look like it reduces relapse. So the potential to relapse is always there, and the effects of or the benefits from therapy look like they're there as well. The other way of reducing the risk of relapse long-term looks like it's through using a more effective regimen, and this is rituximab compared to azathioprine. And so, good doses of azathioprine used in the main RITSAN study that suggests that, in fact, you can get a almost 70% reduction in the risk of relapse over time. Relatively small numbers. You take a look at the y-axis here, the probability of relapse was not nearly as high in these patients as it was in the REMAIN group. And so there's a little bit less certainty just in terms of less accumulated events. And we're still waiting for another randomized trial to be published to look at rituximab-based regimens versus azathioprine-based regimens, but reasonably confident that this is true. Again, rituximab, at least in Canada, is still a little bit more, if not a lot more, difficult to access than azathioprine. And so we use it in more selected cases of patients who had high risks of relapse. I just want to remind everyone that whatever choice you make in terms of a maintenance immunosuppression, that don't forget the safety monitoring, and that includes rituximab. The the risk of long-term severe hypogammaglobulinemia and infections are still there, and the risks of neutropenia are still there as well. The other thing, so I mentioned that in REMAIN, we don't know whether or not that was an azathioprine effect, a prednisone effect, or both. And prednisone is often kind of like the orphan drug that no one studies, but we all have an opinion about what it's doing. We did do a systematic review a long time ago now of protocols that had discontinued glucocorticoids within 12 months, and that's called the early withdrawal group down here. Those that discontinued glucocorticoids, but after 12 months, called late withdrawal, and those that had no plans to ever withdraw glucocorticoids, although they may have been withdrawn in some patients. And we looked at just what the risk of relapse was for each of these. And you see this fairly striking dose response curve, in that the longer that you go on glucocorticoids, the less there was a chance of relapse. Now, this is not a randomized trial. This is really just a natural history experiment. And there's lots of potential confounding problems, but it's pretty striking, this relationship. And so, and there is a bit of a biological basis even for low dose glucocorticoids that fall under the threshold for many of the side effects that we worry about. And so I do urge people just to think about whether or not this should be part of their long-term maintenance regimen. So in summary, immunosuppressives really give very similar disease control. Faster tapers of glucocorticoids reduce serious infections. Plasma exchange reduces the risk of permanent dialysis, but increases the risk of serious infections. And different patients have very different risks of relapse, which may affect not only how you think about your induction regimen in terms of the duration and amount of cyclophosphamide you're giving, but then how you'll treat them with what agent and for how long once they have remission induced. So back to our patients. I like to try and ground these in numbers. So our patient who has the RPGN with a creatinine of 470, but no diffuse alveolar hemorrhage, their risk of kidney failure is roughly 15% if you just treat them with standard immunosuppression. And if you add in plasma exchange, that probably drops to about 9%. The risks of serious infections is high to start with, and it increases with plasma exchange. So I think the other side of this is to be very wary of the possibility of infections in them and to treat them aggressively if they do happen. In our patient with diffuse alveolar hemorrhage, their risk of kidney failure, even if their creatinine has changed a bit in the last year or from their baseline, is still very low. It's only about 0.1%. So adding plasma exchange here wouldn't really alter their risk of kidney failure because it's so low already. And it wouldn't change their risk of death from diffuse alveolar hemorrhage. But their risk of serious infection would go up. And you should think about whether or not you would really want to lower the glucocorticoids and add plasma exchange to try and offset that. But glucocorticoids lowering, measurable but demonstrable benefit, plasma exchange, not really demonstrable benefit so far. And with that, I'd like to say thanks, and I'm happy to answer questions.
Well, thank you so much, Michael, for giving a master class on ANCA vasculitis and its management. So thank you very much for summarizing the data and making some recommendations. Now, there are many questions on Q&A, and I'd like to quite a few participants have asked about the role of IVIG. Michael, would you like to comment on the role, if any, of IVIG in the management of ANCA vasculitis?
Yeah, it's a wonderful question and one that we're thinking about very frequently these days. So I can tell you that the data describing the effects of IVIG are not plentiful. But there is one small randomized trial looking at it as in more of a maintenance role. And I would describe it as having the effect of like giving a month's worth of moderate dose glucocorticoids. And so the way in which we use IVIG is twofold. So one is in the critically ill patients who are definitely infected or who are at such high risk of infection that we're very hesitant to treat them with high dose glucocorticoids, and they have ongoing disease manifestations like pulmonary hemorrhage. We often give them 2 grams per kilo of IVIG separated out over 2 days. And then we sit back and wait because we're worried that those patients die of infection so frequently. We don't plasma exchange those patients because of the infection potential with plasma exchange in the extracorporeal circuit. So we just give them some IVIG and then we tend to sit back. And anecdotally, it seems to have been a reasonable strategy. Those patients are still at very high risk of death, though. The second place we use it is actually in our patients who have been on rituximab therapy and have permanent hypogammaglobulinemia with recurrent infections. And we'll often have them on either subcutaneous immunoglobulin or our monthly IVIG in order to decrease the risk of infection. Those patients have typically been our patients who are also the most frequently relapsing. And again, anecdotally, I would say that we've had really good luck that we continue their rituximab without further change in their immunoglobulin levels. And they seem to do really well, both in terms of reduced infection risk, and they often go disease-free for years and years. So it's a small number, but that's where we've used it. We have not used it in conjunction with plasma exchange on any kind of routine basis. Although some people do recommend that what they do is they do plasma exchange and then they immediately replete after a series of plex with IVIG. There's certainly a sort of a common sensibility around that, but it's not a well-tested strategy, I would say.
Well, thank you for those comments. There's also a question on the role of adding azathioprine. The question is whether there is a need to add azathioprine after using rituximab. I remember in most of the rituximab trials, many of those trials did not follow up with azathioprine, although in the rituximab trial, one arm did compare rituximab followed by azathioprine and rituximab followed by more rituximab. So the question is, what is the role of azathioprine after rituximab, Michael?
Yeah, so this is a difficult area. And part of it is the way that I think that we originally thought about the treatment of ANCA-associated vasculitis, where we think about it both in terms of a complex regimen and that we're going for a cure potentially at the beginning. Most of the thought about treating it like we're going to cure the disease hasn't worked out very well. And in fact, every time we discontinue therapy, the risk of relapse goes back up. So I think it's actually probably better to conceive of ANCA-associated vasculitis the same way that we think about things like atherosclerotic heart disease. The risk is always there. It's always in the background. And think about the therapies then any therapy you give that is known to be effective will continue to be effective for a long period of time. So if you treat a patient with rituximab induction, it doesn't mean that you have treated their risk of relapse in the long term. It's just that the rituximab hangs around, or the effects of the rituximab hang around for quite a while, and then it will wear off at some unpredictable time in the future, and you will unveil their background risk of relapse, which again varies dramatically. So you might feel like you're doing great, you're getting no relapse, possibly because you're treating mostly patients with low risk of relapse. When you start treating patients at high risk of relapse, the relapse potential comes back out. So I dissociate the way that I think about what the induction agent was with whether or not I'm going to give them a maintenance agent and what type it is and for how long. Our typical is that we start azathioprine in people who are at risk of relapse between 4 and 6 months after the rituximab, and we continue it on for about 2 years, 18 months, and then we talk to them about whether or not they're having any side effects and their tolerability of the drug and what the likely benefits are going out past 18 months to 2 years of treatment.
Thank you, Michael. Raja, how are we doing for time? I know it is 8 p.m. now in India. Do we have more time?
Yeah, we do have some time, so that should not be issue. We can quickly run through question. Yourself and Professor Aman can take a call on that. And Dr. Aman may state the Indian perspective of managing vasculitis as well. Yeah. Go ahead, please. We have some time.
Hello.
Hi.
Raja, thanks Dr. Walsh for such a clear and fantastic talks, I must say. The questions, and I would rather compliment you for busting the myths in this live presentation. with very clear messages that, we use a lot of cytoxan induction. That's more because of the economic reasons. And we haven't really had any major issues with IV pulse cyclophosphamide as compared to, say, rituximab. And I'm happy that you've driven home that point that IV pulse cyclophosphamide and rituximab in induction, the outcomes and infection rates are similar. And I think that one table that you showed drives home that point to most of the listeners. The questions that, there are various other questions which people have asked. I mean, one thing is, although you kind of partly answered it, is there any, when do we start the, say, for example, if cytoxan has been used for induction, at what time do you give maintenance rituximab vis-a-vis azathioprine? I mean, that is one question. Would you wish to answer that now?
Sure. So that's actually, it's a great question because it's actually not that straightforward. It depends on when you stop your cytoxan. And there are very different attitudes around the world, I think, about the evils of cytoxan. So there are some people who are like, cyclophosphamide is a bad drug. We should minimize exposure to cyclophosphamide as much as humanly possible. Other people are like, I don't know, I'm pretty used to dealing with cyclophosphamide and we don't seem to run into a lot of problems. I'm of the latter group. We still use quite a lot of intravenous cyclophosphamide. I feel like we have become very good at dosing and avoiding side effects. And if anything, we tend to dose a little on the lower side compared to what our targets were in the trials. So I am definitely a round down person in terms of my 2 mg per kilo target dose. And there is, the data on the cumulative exposure to cyclophosphamide and risk of relapse is actually quite good. So the patients who are most likely to tolerate cyclophosphamide are also those who tend to be at the highest risk of relapse. They're young, so they have a long cumulative history. They have a little bit less kidney involvement, so they tend to tolerate all of their drugs a little bit better. They therefore have the higher risk of relapse. So I tend to go for the full 10 doses in 6 months worth of IV cyclophosphamide, and we tend to start our azathioprine 4 weeks after that. There are a lot of units around the world I know that will only go to the 3-month mark or 6 doses of IV cyclophosphamide unless they think that there's a problem. And they would start typically also about a month after their 6th dose of cyclophosphamide. There's a good rationale for that. What I do is I always order it as 10 doses. And if people have a tolerance issue, then I'm okay to stop it early. But if they don't have a tolerance issue, then I just carry out to the 10 for the likely benefits of lower relapse over the next 5 years.
Thank you. I think the other important question is that, is there any role of ANCA titers in assessing remission or relapses?
Yeah, that's a great question too. And this is also, I think, oddly more controversial rather than less controversial over time. So the non-controversial part is that if the ANCA remains measurably positive at the time that people are switching from induction to maintenance therapy, whether that be between 3 and 6 months, then those patients are at higher risk. Can you still hear me? Sorry.
Yes.
Okay, sorry. One of my earphones just died. So beyond that, though, it doesn't mean that they're having a relapse. It just points out that their lifetime risk for relapse is going to be higher. The controversy starts to become for those who go from negative to positive, and to whether the degree to which that says that they will be at higher risk later. I think most of us agree that they probably are at higher risk, although it's hard to quantify that degree of risk, and it doesn't give you any guarantees around timing. And for those who are positive at 3 to 6 months and then go negative at 1 year, how much lower is their risk? Again, I think we will generally agree that their risk is lower, but how much lower and whether or not that changes our minds about their therapy is very controversial. We tend to measure it once at 6 months, and then we say, don't measure it a whole lot after that. There's very few patients we will measure it again somewhere out around the 3 to 5 year mark if we're trying to reestablish what their risk of relapse is and choices around their duration of therapy.
I think another question is that how long do you give maintenance therapy? I think, again, I don't think we have trial data for the duration of therapy, but that's a very important, relevant clinical question in the day-to-day practice. So how long do you treat?
Yeah, again, great question, very difficult. And I will be completely transparent that I went from a practice as a young man of stopping everyone's therapy aggressively, believing that we probably could and that I was doing them harm by keeping them on therapies they didn't need, to now being the exact opposite and keeping people on therapies for very long periods of time based on their degree of relapse risk. So my approach is that what we do is we talk to patients about what we think their expected risk of relapse is, and I just slot them into one of three categories. I say you're either relatively low risk, only about 3% per year, you're at high risk at around 10% per year or higher, or you're at an intermediate between those two. And I say that if you take therapy, then your chances of having a relapse are reduced somewhere between 30 and 50%. And so if that's 3% per year, you go down to 1.5% per year. If you're 10 to 15% per year, you're still at around 7% per year on therapy. And we say that means you have to keep taking pills and getting your blood work checked on a regular basis. But you have a lower risk, but never a zero risk of relapse. And we have a maximum sort of duration of therapy that people go being relapse free of somewhere between around 7 years, because the epidemiologic data suggests that the risk of relapse actually does start to decrease after that point, although not really before that point. The instantaneous hazard is pretty constant up until about 7 years. And we find that a lot of people go like, well, I'm tolerating therapy so well, why would I bother getting off of it now? There's a few people who are, just like, I really don't want to take pills, and so I'm willing to take that risk, and we'll just monitor more carefully. And we individualize treatment in that way.
I think, again, towards the end, as we come to the end of the session, there are two important questions. One is whether there is any scoring system which can predict the serious infections in PLEX when the creatinine is more than 500.
So no scoring system yet, but hold that place. We're just discussing how to get up with better risk prediction for serious infections across the entire spectrum. The risk for patients who are on dialysis greater than 500, though, is typically estimated to be somewhere between 30 and 50% in the first 6 months. It's really high. Like serious infections for these folks is just really common.
And the end, last question. I think you so beautifully shown the role of PLEX and various guidelines which have followed the PEXIVAS trials. There is a talk of kidney histopathology wherever it is available, and some kind of a scoring system to guide the PLEX in patients with advanced renal failure. What's your take on that?
Yeah, this is a tough one. So PEXIVAS had a fair bit of commentary or scrutiny over the fact that we did not require patients to have a biopsy before going in. And so it led to the comment that, well, maybe that there's a lot of patients who went into PEXIVAS that had such fibrotic kidneys that, in fact, there was no possibility of benefit. I would argue against that pretty heavily. In fact, the observational evidence so far suggests that there is, in fact, no point of no return. So there's no kidney biopsy that we can identify that has a 0% chance of recovery. In fact, the closest we can get is probably about only a 20% chance of recovery. Even then, that's probably a bit optimistic in saying that there is a point of no return. And the realities is that we biopsy fewer patients now with widespread availability of ANCA. The creatinine is probably a more prognostic marker of their kidney outcome, more representative of their global risk. So there is this BRICS score. Silky Bricks has proposed a scoring system to try and help, but it uses very little creatinine information. It just dichotomizes creatinine, and so it actually doesn't calibrate particularly well. And we will be publishing shortly the information that you saw about just prognosticating with creatinine alone, which I think actually performs extremely well.
I think one last question before we wind up. We haven't had very good response with mycophenolate, and that's been experience of few of our colleagues also, because we see more of PR3 positive ANCA vasculitis as compared to some trials having more of MPO. And even the cyclophosphamide versus mycophenolate trial, it showed that the patients who are PR3 positive don't really do well, and perhaps it's the milder disease which. So what's your finally, because do you put them at par with the cyclophosphamide or rituximab, or versus maybe in very select patients of high, because that would be very important from the practice perspective.
Yeah, so for me, the evidence that MMF is inferior in ANCA-associated vasculitis to almost everything else looks reasonably solid. I think the place where it's most commonly argued as a residual role is if you don't have access to rituximab and you don't want a young female to be treated with cyclophosphamide, then consider MMF. And in fact, I do a pediatric transition clinic where we get our pediatric cases over, and they're frequently on mycophenolate and doing reasonably well. And the one thing that I do find is every time I try and stop their MMF, they have a relapse. So if they're doing well on the MMF, I can carry it on, but I very rarely will start off with MMF. And in fact, I would prefer to use, low dose cyclophosphamide, only give them 6 grams of exposure to cyclophosphamide as a pretty predictable method of treating them. And then carrying on with very traditional immunosuppression and azathioprine afterwards.
Thank you very much. I think I'll now hand over to my co-chair and Raja for winding up this session. Thank you very much. I must compliment you. This is one of the most crisp presentations that I've ever heard. And we've had very big people in ANCA vasculitis field, even coming to rheumatology circles and to PJI. But I must compliment you, the very crystal clear, practice-oriented messages. Thank you very much for this enlightening talk. Thank you.
Thank you. Just one clarification, please, Dr. Walsh, if I can ask you. This statement that mild renal failure causes more relapse and severe causes less, as Dr. Sanjay Agarwal has commented. I mean, is it possible that is so because actually there are fewer patients with severe who have relapse because there's more death in ESRD? So can you please clarify on this, and what should be our target like?
So there's
mild renal failure.
Two things to consider. So maybe more than two. So one is that people with really bad chronic kidney disease do appear to have a defect of the innate immune system. So they're prone to more infections. They get all sorts of other things that go wrong with them. Maybe that's protected. We like to hypothesize about that, but we don't really know. In fact, if you take a look at our dialysis unit, the proportion of patients who are naturally lymphopenic on dialysis is astoundingly high. It's a very bizarre thing. No one really has a good explanation for it. So perhaps there is something there. It also makes us think, though, that I may have misestimated the degree to which creatinine is protective. And so whether or not truly your creatinine is over 200, how protective that is, we're not certain yet. The other thing is that we also worried a lot about this issue that, in fact, what happens is that you don't survive to get a relapse if you have end-stage kidney disease. And so maybe that's weeding people out who otherwise had a relapse potential. We've done as good a job as correcting that statistically as we can. It still is maintained that the people with end-stage kidney disease in particular seem to be protected from relapse. The last thing I would mention is that those patients with end-stage kidney disease are much more commonly renal limited disease. And detecting a relapse in someone with renal limited means they have to get a new manifestation. And so that part is much harder to actually tease out from everything else.
Could it also be possible, Mike, that those with initially bad kidney disease, high serum creatinine, tend to be more hammered with heavy treatment right at the start? Is that also a confounding possibility?
Yeah, we've tried to correct for that, but you're absolutely right. There is this, particularly because a lot of it is historic data where people were getting much larger doses of cyclophosphamide if they had severe renal impairment. And as I said, that cyclophosphamide effect hangs around for a really long time. So it's actually very difficult to correct for.
Yes. Perhaps may I allow myself one other question, and then we wind up. And it relates to your observation in your meta-analysis that those patients who received plasma exchange had a higher incidence of infection. Do you think that the relatively large dose of steroids we still continue to use while plasma exchanging may contribute to that infectious risk. And the implication is that if we use much smaller doses of steroids, the infection risk may come down. What do you think of that possibility, Mike?
Yeah, so this is an important sort of concept that those risks appear to be additive, not multiplicative. So if you have a starting risk of getting an infection of, say, 50%, decreasing the steroids brings that down to about 30%. But going back on plasma exchange brings it back up to about 45%. So you can balance it out, but all it does is it just changes the average risk by this additive amount. It doesn't go that I can completely neutralize one risk with one therapy. So I don't believe that we would ever be able to go like, I can completely ameliorate the risk of plasma exchange on infections by using low-dose glucocorticoids, but rather we get it to maybe an acceptable level. Although, I increasingly worry that we need to focus more on the infection side and less on the efficacy side of how we do the therapies.
Well, that's certainly something for us to address in the future, for all of us to address in the future. All right, well, it's 20 minutes past 8 in India. That's 20 minutes past 1 in the morning here. So I think it's time to wind up. I'd like to take the opportunity to applaud your excellent presentation, your patience in answering our questions. And thank you so much for giving us a great talk. And on behalf of Raja and the Indian Society of Nephrology, I'd like to thank you for giving this talk. Raja, would you like to wind up?
Thank you so much. It was a brilliant presentation, and I've received so many messages saying that it was one of the best talks we have ever heard. And thank you indeed. And Chen Au, thank you so much. It's 1:30 in the morning at Adelaide. We are really indebted. Professor Aman Sharma, thank you so much. You skipped picking up your daughter for the talk. Thank you so much. Thank you all. And thanks again. Bye and good night and good day for Walsh. Bye.
Thank you, everyone.
Bye, everyone.
Thanks, Raja. Thank you.
Thank you, Mike.
Bye.
Take care.
Bye. Bye. Bye.
Bye. Take care.